Happy August to everybody.
This meeting is being recorded.
My favorite month to live in South Carolina. Yours too, I'm sure. So the management of preterm labor is matched in its complexity probably only by its level of frustration and the fact that I feel we really haven't moved the needle on this very much, and we'll talk about that more at the end. But I want to start with the very mundane task of defining what exactly labor is. And I try to teach my residents, of all the definitions you have to memorize, this is probably the most important because of its ability to save you pointless work in the long run. So a good definition for labor is the regular and painful uterine contractions that cause progressive cervical dilatation and/or effacement. So why is that so important? First of all, the benefits of identifying preterm labor are such that it allows these following interactions. Probably most important is the ability to administer antenatal corticosteroid therapy. So steroids decrease the intensity and the frequency of prematurity-related lung disease by 50%, probably the single greatest advance in neonatal care in the last half century. It also allows for appropriate group B strep prophylaxis administration. It allows us to administer magnesium sulfate for neuroprotection against cerebral palsy. It allows, if necessary, to transfer to a facility with appropriate level of newborn care. But this definition, as I was implying, most importantly, allows us to avoid the unnecessarily and costly interventions for what actually is not preterm labor. And this statistic shows that 50% of suspected preterm labor subsequently will give birth at term without tocolytic therapy. So very important to identify what is not preterm labor so that you don't have to treat it. Next slide. This is a concept that I learned from Roberto Romero. So he's making the point that if we think about preterm contractions as a symptom, it's very analogous to looking at cough as a symptom. And think about all the variety of things that can make an individual cough. It could be something as simple as an allergic reaction to pollen versus lung cancer. And so you don't actually want to treat the cough per se. What you want to do is identify the underlying cause. And this would similarly apply to preterm labor. So if you have a patient who's contracting preterm, a good example is addressing and identifying, say, diabetes could be the cause of her contractions. And if you treat the diabetes appropriately, you may eradicate the preterm labor. So just remember to identify the underlying cause where possible and not to treat the symptom per se. Next slide. So what do we know about the pathogenesis of preterm labor? They really, almost all these causes could come under these four headings. Something to do with premature activation of the maternal or fetal hypothalamic pituitary adrenal axis. Probably the most important and most common is inflammation and or infection. Thirdly, decidual hemorrhage. And then lastly, pathologic uterine distension. Think multifetal pregnancies or polyhydramnios. Next slide. Clinical findings. What might you find in the patient who presents with preterm labor? They may complain of menstrual-like cramping. They may identify mild irregular contractions. They only may recognize it as low backache. They may notice some unusual sensation of pressure in the vagina or the pelvis. They may have noticed a vaginal discharge of mucus, which could be clear, pink, or slightly bloody, or they may in fact have passed the mucus plug or demonstrate bloody show, or they may have frank spotting or light bleeding. Next slide. So what should entail your diagnostic elevation of this patient? As always, you would start with a focused history and physical examination, focused on known risks for preterm labor, signs and symptoms of preterm labor. You should assess their uterine activity for intensity and frequency and duration. You certainly would want to put the patient on an external monitor and assess the fetal heart rate tracing. Next, you'd want to perform a speculum examination to assess their cervical dilation, look for any evidence of uterine bleeding, rule out premature rupture of membranes, obtain appropriate cervical cultures, and if indicated, as an aside, I would say in our practice, this is a rare thing, obtain a fetal fibronectin assay. Next, you would move to perform a digital examination once you've confirmed that a placenta previa is not present. If you diagnose cervical dilatation greater than 3 centimeters, then that supports the diagnosis of true preterm labor compared to false labor. And I can hear my old chairman's words echoing in my ear that if they're less than 4, you can send them out the door. Almost always will obtain an OB ultrasound unless the patient has had one in the very recent future. And the important information we gather for this is to assess the fetal anatomy if it's not been done before, because there's a definite correlation between fetal anomalies and the subsequent development of preterm labor. It's important to assess the fetal position. Certainly preterm delivery of a breech is an important thing to know. Also looking for evidence of growth restriction, because growth restricted fetuses very commonly will go into preterm labor. And as we've mentioned, amniotic fluid volume, both oligohydramnios, but more likely polyhydramnios can be associated with preterm labor. Again, looking at placental location, making sure that's normal and that there's no evidence of placental abruption, though as we all know, placental abruption is generally a diagnosis of exclusion, and any placental bleeding usually will have escaped through the cervix and not be visible on an ultrasound. But in rare cases, there can be concealed placental bleeding, which will be visible on an ultrasound. And then in some cases, assessing the appearance of the cervix can be helpful in patients who are in early preterm labor who have not dilated their cervix. You can monitor their cervical length to help you make the diagnosis. Next slide. What laboratory studies might you want to consider, in addition to just sort of the routine admission laboratory studies? You might want to obtain a GBS culture if one has not been done in the previous 5 weeks. We would like to obtain a urine specimen for culture because there's a link between asymptomatic bacteriuria and preterm labor. We usually will collect labs for sexually transmitted diseases. And then again, rare but select indications, you might choose to do a fetal fibronectin. Next slide. So how do we manage these patients? So let's first just talk about those who present at 34 weeks or more. We're unlikely to do any sort of major intervention at this point. So we monitor them over the first 4 to 6 hours. If there's no evidence of continued labor, then we're likely going to send that patient home. If we think they are in labor, then we're going to admit them for further observation. We would just manage them as we would any normal laboring patient. We would certainly consider administration of steroids between 34 and 37 weeks if they had not already received those at some point prior to their admission. But we would consider steroids kind of under the guidelines of the ALPS trial, but we would not tocalize them to allow steroid maturity. Prior to 34 weeks, you would consider that. And then we would evaluate them for the appropriateness of GBS prophylaxis. Next slide. But what if they're less than 34 weeks? We make the same initial discernment as to whether or not they're truly in labor, and if not, we would send them home with preterm labor precautions. If we felt they were in labor, we would admit them. We would administer corticosteroids, a rescue course if one had already been administered if we felt that was appropriate. And we talked in a previous meeting about the nuances of holding that final rescue course where you would get maximal clinical benefit. We would administer tocolytics in this particular clinical presentation for the specific purpose of allowing the 48 hours that it takes for the fetus to gain maximal benefit from pulmonary maturity. And there's a lot of individual variation in which actual tocolytic drugs are used. The most common ones I would say are magnesium sulfate, calcium channel blockers like nifedipine, and non-steroidal anti-inflammatory drugs like indomethacin. Less common are beta-2 agonists, but there's a lot of institutional variation over which of these are used. Most people try to avoid polypharmacy, so they try to stick to an individual tocolytic, but in rare cases, especially with extreme prematurity, some people will use more than one tocolytic. GBS antibiotic prophylaxis is administered, and then in general, magnesium sulfate for gestational ages less than 32 weeks is administered for neuroprotection. And just to remind us what the value of that is, the number needed to treat to prevent one case of cerebral palsy is 63, and that's a fairly favorable number, so most people would agree with using it. The relative risk for prevention of CP is 0.68, so that's a pretty good number. Just as a reminder, there's no apparent benefit for an antibiotic administration beyond treating a documented infection of some type or for GBS prophylaxis. There's also been no demonstrated benefit of progesterone for the treatment of acute preterm labor other than one small Italian study that I'm aware of where I think they gave intravenous progesterone and showed some benefit, but that's never really caught on or been demonstrated in other trials. And then just in closing, what is the benefit of all this? We can certainly say that tocolytic therapy is more effective than placebo for delaying birth for 48 hours in randomized trial. So that's the time that you need for steroids to take their effect. So that is a win for us. But they don't really seem to be effective at extending the duration of the pregnancy as a whole. Even when tocolytics are administered, approximately 50% of patients diagnosed with preterm labor give birth at term. So that just underscores our limited ability to diagnose true preterm labor. And then the graphic at the bottom is just an overview of the incidence of preterm labor nationwide. And this is pretty much reflected in our South Carolina data as well. It's been very flat to slightly increasing over the last decade. And we might could have a discussion of what that is. It's clearly multifactorial. It seems that our patients sadly seem less healthy today than they were 40 years ago. And I think this is probably partially why the rate has increased, but some of it is a mystery. But the stake in the heart is just the fact that we have done very little to move the needle in regards to the incidence of preterm labor nationwide. And we don't compare favorably with other developed countries around the world. So it's a real sticking point for us. Let me just stop there.